Ladies and gentlemen, welcome once again to another episode of the Think Clinical Podcast. My name is Hamza. It's amazing to be here once again, and I do appreciate all the subscriptions, all the support. Thank you so much for all you do for this channel. Today we are going to be talking about what goes beyond all the team building activities we do, especially in healthcare organizations. Why psychological safety matters more than culture. And I know this generates a lot of conversations where people spend millions and millions in organizations that I've seen and probably worked for, spend millions on team building retreats, personality assessments. They do culture initiatives, but meanwhile we have preventable medical errors that remain the third leading cause of death in the US and most parts of the world. So the question I was asking myself is, what if we are focusing on the wrong thing? And I know these conversations came up especially during my MBA program, where we were able to look into what some of these will look like. What if team's culture is actually a distraction from what research actually shows? Because a lot of the research that I saw and a lot of the research that I read had a lot of backing for psychological safety and just its role in error management or reporting errors in organizations. So when we look at the Harvard research by Amy Edmondson, there was 2 decades of studying high-performing teams. And her findings surprised everyone because the best teams don't make fewer mistakes, they actually report more of them. And the difference between it isn't the culture of the company, it's safety. And as we progress through this, I will tell you why the culture measurement is a problem. Like, where does that problem lie? And you would learn to understand that every organization has its own subjective outlook on what culture or a good culture in the organization looks like. So, and I've heard this from so many people, when we look at just how vague it is when we talk about culture. First of all, every organization thinks they have a good culture. There are very few organizations that I have seen or worked for that can admit to the fact that, hey, we need to do or improve our culture in so many different ways. But a lot of organizations, and even a lot of small organizations within the big organization, think they have the best culture. And whenever I asked them what that meant, there were a couple of things that came up. One of the common ones is that people care about each other. That's why we think we have a good culture, right? What does that even mean? We communicate well. Okay, what does that even mean? Everyone is committed to excellence. Okay, yeah. What does that mean? We are like a family. That's the most common one that I see. And I'm like, okay, how do you even measure any of these things? What's the impact of some of these things on the organization? Is this just because you think you're like a family, or you're actually like a family, right? None of these predict performance, because there's no research that actually shows how any of these statements have actually predicted performance. And the family metaphor is actively harmful because families don't fire underperforming members, right? So sometimes you see people who are not doing well. The same people who said we are families actually come to you and say, hey, we need to get rid of this person because they're not performing as they need to. But if your family member was actually not performing well, I don't think you go ahead and say, well, my brother is not performing too well, so we're going to fire him from the family. And not so stuff like this actually make me think we are making excuses for what we think, replacing what I think should be psychological safety with culture as an organization. So when we look at the 2023 BMJ Quality and Safety Study, they examined 89 hospitals' self-reported culture scores and correlated them with patient safety outcomes. The results, there was no relationship. Now, hospitals rating their cultures highest had the same error rates as those rating their culture low. That's why I said some people have a good level of introspection to be able to say, okay, our culture is not as it's where it needs to be. But when they look at those and the other ones that actually said, well, we have a great culture here, the error rates were not different. So why? Because culture as is typically measured or typically seen captures, unfortunately, a social desirability bias. What does that mean? We want to think our team is great, right? The second thing is that it captures the halo effects, which is good recent experiences, color, overall perception. So you do something good and the first time that is done, you assume that it wipes out everything that has happened in the past. That wasn't a good culture, and I came to that realization recently. And we have what we call the survivorship bias, where people are left due to poor culture aren't surveyed. So people leave because the culture of the organization is not good, and there are no exit interviews or surveys that actually capture some of these feedback. So this is why culture is not really the right way to think about this. But then there's a dangerous narrative here, because when adverse events occur, blaming culture provides comfortable distraction that avoids addressing the concrete systemic failures. So you just say, okay, we need to fix our culture. What does that even mean, right? So there are systemic failures that need to be tackled, but they are all blamed on culture. Our culture needs improvement. It feels less confrontational than our scheduling system forces dangerous staffing ratios, or our hierarchical communication structure silences nurses who catch physicians' errors. These are systemic issues that could have been fixed, but unfortunately we blame that on culture. So culture talk often substitutes for structural accountability, which should be what we should be doing at this time. So what actually predicts team performance? Now, when you look at Google's Project Aristotle, it analyzed 180 teams to identify performance factors. Culture and cohesion ranked low. Now, the dominant factor there, guess what, was psychological safety. And psychological safety is defined as the shared belief that the team is safe for interpersonal risk taking. Again, psychological safety is defined as the shared belief that the team is safe, the team, not individual, the team is safe for interpersonal risk taking. So specifically, we are talking about speaking up about errors that would result in punishment, because that's what usually happens. Asking questions won't be seen as ignorance. Challenging decisions won't be career limiting. Admitting I don't know is acceptable. Those are the components of psychological safety. So you can speak up without the fear of being punished. You can ask questions that wouldn't seem to come off as you looking ignorant. You can challenge decisions, and that won't be career limiting, because the next time there's an opportunity for a promotion, you're not considered. And admitting you don't know is acceptable by everybody. Those are the components of safety. And why this matters in healthcare is because this is an error-prone environment. So we have complex patients, we have time pressure, we have incomplete information, and we have cognitive limits that guarantee mistakes. Again, it guarantees the mistakes. So the question isn't, do we make errors? The question is, do we catch and correct them before they cause harm? That is what you need to incorporate as in terms of what psychological safety is. And when we look at the research, and some of the big ones, which probably looked at about 1,200 plus hospitals, they found psychological safety scores predicted 48% variation in error reporting rates, 32% variation in near miss identification, and 27% variation in patient safety outcomes. Not culture, not team cohesion, psychological safety. So we need to be looking at this from that perspective. Now, what are some of the structural determinants of safety or psychological safety? Because they are not built through trust falls, they are engineered through organizational design. So that's what we need to look at. So the 4 structural factors that actually create safety. First one I call the authority gradient management. So healthcare has a steep, we have very steep hierarchies in healthcare. So there's a nurse, there's a doctor, like the hierarchy is so steep that people are finding it difficult to speak up, which is one of the components of psychological safety that I mentioned. So these steep gradients kill patients when junior staff won't speak up, and that is something that we need to avoid, and we need to make sure that we have built in. So when you look at the Vanderbilt study of surgical errors, it found 45% of preventable complications occurred when nurses or junior physicians noticed problems but didn't speak up forcefully enough to stop the case. So the intervention here is that we need to flatten that gradient structurally. There has to be mandatory briefings where all team members contribute. Open up the space and allow people to bring up all their suggestions and everything they've seen. And this shouldn't be met with punishment or shouldn't be punitive in any way. You need to stop the line authority for anyone. Then this is borrowed from manufacturing. And you need flat communication protocols during critical events. Use first names, not titles. Don't say Dr. Hamza, say Hamza. You make sure everybody feels comfortable enough to be able to do that. And this has been done in Johns Hopkins, and where they have the comprehensive unit-based safety program that structurally empowered nurses. And the result, 40% reduction in catheter-related bloodstream infections. So these are the things that we need to be talking about. The second thing is error disclosure and learning systems. So most healthcare organizations say we learn from our errors, but structurally punish those who report them, right? So what percentage of reported errors result in individual disciplinary actions versus systemic design? That's a question you should ask. And more than 30% lead to individual consequences. That's a huge percentage. So guess what? People are not going to talk about these, and you have a punishment system that is disguised as a learning system. So these are some of the things that you need to be looking at. So the alternative structure is just a just culture algorithm. So separate human error, which is a system problem, from an at-risk behavior which needs coaching, from a reckless behavior which needs discipline. Again, if you create a just culture or algorithm, you are separating the human error, which is a system problem that you need to fix, from an at-risk behavior which needs coaching, mostly at the individual level, from a reckless behavior which needs discipline. So organizations using just culture frameworks have reported about 300 to 400% more safety events, not because they are less safe, but because reporting is safe. They can come forward and talk about this. The third point is cognitive load and capacity design. You can't just have psychological safety when people are drowning. Overloaded physicians don't have bandwidth for reflection, speaking up, or error recovery. You have to be able to create a structure, and some of the structure indicators are alarm fatigue, greater than 100 alerts per shift, right? Interrupted workflows, greater than 40 interruptions per hour. Documentation design, more than 2 hours per day on the electronic healthcare record system. Decision fatigue, more than 50 complex decisions per shift, right? These are some of the things you use to learn. So how do we fix this? You build Slack into systems. Mayo's study found that ICUs operating at 85% capacity had better outcomes than those at 95 plus. So the inefficiency was actually a safety capacity, right? So, and then the learning architecture, which is the fourth point I want to bring up, is that most organizations do one-time training and they expect every employee to be an expert. High reliability organizations build continuous learning structures. Again, I'll use Johns Hopkins as an example. The daily briefing structure, and they have some 10 minutes at the start of the shift. Every team member shares one safety concern, no defensiveness allowed, concerns documented, monthly review which concerns became interventions. This isn't culture. It's structured practice of safety behavior that eventually becomes habitual, right? So these are some of the 4 things that we need to be looking at. And the last thing I would like to look at is that how does AI adoption connect in all of this? How does AI amplify safety dynamics? We have the trust calibration, which requires questioning. So clinicians must feel safe asking, why did AI recommend this, right? They must admit, I don't understand how this works. They must also challenge the recommendation doesn't match my clinical judgment. And I always talk about AI in all my podcast, because it's becoming a big part of healthcare that we cannot ignore. When we talk about error reporting becoming more critical, AI failures need rapid reporting for algorithm refinement, and then false positives or false negatives must be documented, in edge cases where AI fails must be captured. So these are some of the things that we need to be looking at as a group. So the practical implication of this is that for healthcare leaders who want performance, not performance theaters, stop asking, how do we improve culture? How do we build team cohesion? Or what team building activities should we do? Stop asking those questions. The question you should start asking is, can any team member stop a procedure if they see a safety concern? What percentage of reported errors lead to system changes versus individual discipline. Remember, I said right now more than 30% of these lead to individual discipline. We have to be able to separate these and intervene accordingly. And do junior staff feel comfortable challenging senior staff decisions without consequences in the future? How do we structurally reduce cognitive load? These are the questions you should be asking as a healthcare leader and trying to figure out how you can work through this. So actionable structural changes, you can implement speak-up protocols, right? I'm concerned, I'm uncomfortable, this is a safety issue, right? Create error learning systems, anonymous reporting mechanism, just culture assessments. Like I said in the beginning, you have to design cognitive capacity as a third point, which is audit alert burden, eliminate non-clinical alerts, build 10% slack into scheduling, protected time for documentation, and then you measure what matters. Don't measure employee engagement score, don't measure culture survey results, team cohesion ratings, but measure error reporting rate, speaking up frequency, time between error and system change, cognitive load indicators. These are some of the things that you need to look at. So the key principle here is that culture is emergent property of structures. Change structures, when you change structures, culture follows. Trying to change culture without changing structures is wishful thinking, and this is where we need to be looking at. So high performing healthcare teams aren't just built through retreats or just exercises. They're engineered through structures that make safety behaviors rational, expected, and rewarded. This is where we are as organizations. Then this is how we need to be looking at things. Let's look at organizational safety as a key component. Try to drive culture eventually, and not define culture before we actually know what it means. This has been another episode of Think Clinical Podcast. Thank you so much. My name is Hamza, and I'll see you in our next episode.